gentlemen, you are welcome to another webinar in the series of webinars organized by our friend Professor Booker. Now, my topic is technique of anatomy scan of the extremities. That's the topic I was given. So I intend to follow this outline as a guide for my presentation. We'll have an introduction. We then proceed to discuss the technique of scanning the extremities, and then I will illustrate what I've discussed by talking about some anomalies. And then I will now look at some clinical cases, and then I will conclude. Now, imaging fetal extremities has been a time-tested modality in the diagnosis of the normal and abnormal fetal limbs. An examination of the extremities, although not listed in some guidelines such as the American Institute of Ultrasound Medicine for standard obstetric sonography, however, it is a critical adjunct to fetal imaging and is needed to diagnose many fetal syndromes. Fetal extremities consist mainly of bones and soft tissues. We have long bones as well as short bones. And the bony structures are easier to visualize than the soft tissue with the ultrasound. In early trimester, the bones are not fully ossified, and visualization of the fetal bones at that phase of fetal life is not easy. Now, what are the bones of the extremities? In the upper limb, we have the humerus, we have the radius and the ulna. And in the lower limb, we have the femur and tibia and fibula. In addition, there are also small bones of the hand and of the feet. Now let's look at structural differentiation of bones of the extremities. Now, to differentiate the different bones of the upper and lower extremities in utero, one has to adopt a method that can be used in all situations and can be replicated and used by all individuals. This, I think, is the best approach, systematically going through all the limbs. Now, the best method, like I said, is systematic. And this must be complemented using fixed landmarks, because the landmarks will serve as the starting point. For the upper limb, the landmark is the scapula. And for the lower limbs, the landmarks are the iliac crests. And for the optimum condition for fetal limb examination is affected by fetal position. That must be clear in our minds. And all limbs are best visualized when freely floating in amniotic fluid than when they are tucked under fetal body. Because if they are tucked under fetal body, it will be very difficult to see them and delineate them. Now, fetal limbs are better imaged when the fetus is in supine position. Now, these are the ideal conditions that will facilitate easy differentiation and examination of these fetal bones in the upper and the lower limbs. Again, there are two cardinal movements in limb examination. The first is rotation. A rotation elongates the bones. The second is sliding, and sliding brings it into full view. Now, again, all long bones should be visualized with a systematic method and routine sonographic approach to minimize errors in detecting limb defects. So being systematic is key to visualization and examination of all long bones. Otherwise, one may incur error while scanning and examining the fetal limbs. Let me give an example of a systematic approach. Now let's look at the examination of the upper limb. In a survey of the upper limbs, the scapula, like I mentioned, should first be located because it is a fixed point and it will be our landmark. Then the probe is laterally moved to identify the humerus, which at first may be in cross-section. And when you rotate the probe, you obtain the longitudinal view of that particular long bone. Now, after completion of the upper arm assessment, the transducer is moved to visualize the distal end of the humerus or the elbow joint, which is another landmark. And the probe is meticulously adjusted to locate the proximal end of the radius and the ulna. Similarly, after going through examination of the forearm, the wrist joint and the hands will be demonstrated respectively. The lower limb survey must be approached in the same way from the earlier crests through to the foot of the baby. Now, how do we identify the bones concerned? The simple technique to identify the type of long bones is to obtain planes of section that traverse the short and the long axis of the limb. Such a plane through the forearm and calf will demonstrate two bones. In the lower leg, the more lateral bone is the fibula, and the medial bone is the tibia. Now the tibia and the fibula and radius and ulna end at the same level distally. However, when you look closely proximally, the ulna is longer than the radius, and that will serve as a differentiating parameter between the two bones. And this allows ready differentiation of these two bony sets and of the radius and the ulna in the upper extremity bone sets. Now looking at this image is an image of the upper and the lower limb. Now let's consider the first image on the left, which is that of the upper limb. The humerus is clearly seen because it is well ossified. And if you follow the distal end of the humerus, you can see the elbow joint. And from there you can see the ulna and the radius. And if you look more closely, you will have seen that distally the two bones end at the same level. But if you look proximally, you will have observed that the ulna is longer than the radius. Now let's look also at the lower limb. You can see the femur clearly defined, then you can see the knee joint, and if you follow downwards, you will see the two bones, the tibia and the fibula. Now again here, the tibia and the fibula distally end at the same level. However, if you look proximally, you will have seen that the tibia is a bit longer than the ulna. So these are classical ways to identify the two bones of the upper, the three bones of the upper and lower limb. There is no difficulty in identifying the humerus. It was because, like I said, the landmark there is the scapula. Now, there is also no difficulty in identifying the femur because the landmark there are the iliac crests. Now, let's look at the features when examining the fetal limb extremities. What are the things that we must look at while trying to assess whether the bones are normal or they are abnormal? So the first parameter is the length or dimension of the bone. The second is the degree of mineralization of the bone, which is indicated by the degree of echogenicity of the bone. The third is the contour, whether that bone is straight, which is the case, that is normal, or otherwise. And then you look closely at the bone for evidence of fractures. And these features will define normality or otherwise in the bone in question. Now, how do we measure the length of the femur? Femur length measurement is usually used as a means of predicting gestational age. And the measurement is technically the easiest of the most common biometric measurements when you are examining the long bones. It's the easiest when you are doing fetal biometry. Now, the transducer need only to be aligned to the long axis of the bone to obtain a proper plane of section, because you need to see the bone in its entirety before you can take your measurement. And when you are taking the measurement, only the ossified portions of the diaphysis and the metaphysis are measured. The cartilaginous ends of the femur are excluded, so you don't include that. And if you do that, you will have a spurious measurement, which will now invalidate your gestational age. Now, this is a sketch of the femur depicting its two ends and where we need to place the calipers as we measure this particular bone. Like I said, the epiphysis are excluded. Only the diaphysis is included in the measurement. And this is clearly demonstrated in this particular sketch. Now, if you look at this image, is an ultrasound image of the femur. The bone, you can see, is in horizontal position. And you can see that the bone is well ossified. And the calipers are placed at the two extremes, depicting only the diaphysis. It is important to note the following: short, long bones. Now, a fetal long bone length greater than 2 standard deviations below the mean for the gestational age does not necessarily indicate the presence of a skeletal dysplasia. This is very important to note. Other possibilities for short, long bone include: 1, a normal physiological variation in the bone length; 2, intrauterine growth restriction; and 3, chromosomal abnormalities and other syndromes that may have a skeletal abnormality as part of their presentation. So we have to be very careful when we see a short bone. These may be the possibilities to explain why a long bone appears short. Now, what about identification of the hands? With patients, one can usually visualize all 4 fingers and the thumb. The hand is frequently in a clenched like fashion, which can complicate the counting of the fingers, but this is what happens in most cases. The toes, on the other hand, although smaller than the fingers, can be seen relatively well. However, if difficulties arise, it is usually the functionally less important 4th and 5th toes that are not seen. So this has to do with evaluation or examination of the hands and the feet. Now, this is an image that clearly depicts the appearance of a normal hand. You can see the 5 fingers, including the thumb, which is clearly demonstrable here. Now, sonographic features of skeletal dysplasia should also be discussed. And the major sonographic features that are highly associated with the presence of a generalized skeletal dysplasia are: 1, shortening of the extremity bones, bowing of the bones, presence of fractures, evidence of demineralization or hypoechogenicity, and also the presence of a small thorax. So this may be harbingers of a skeletal dysplasia. Now, there are minor sonographic features that may aid in the differential diagnosis but may often be seen without a generalized dysplasia, and this include polydactyly, malalignment, abnormal configuration of the calaveria, focal skeletal defects, an unusual appearance of the bones, spinal abnormalities, mid-face hypoplasia, ventriculomegaly, polyhydramnios, and sometimes in extreme cases, hydrops fetalis. So these are minor sonographic features that may aid in the differential diagnosis, and they may not necessarily be as a result of a skeletal dysplasia. There are other also important features suggestive of skeletal dysplasia. What are these? Fetal part ratios. Very important. The proportion between specific fetal body parts may be helpful in the diagnosis of a skeletal dysplasia. For example, the foot length. The foot length is usually not affected by most skeletal dysplasias, whereas most other bones are affected. So this is a point we should note. In a normal fetus, the femur length and foot ratio, the femur length foot ratio, which is age independent, is approximately equal to 1 and can effectively distinguish skeletal dysplasia from fetal growth restriction. So if you take this ratio and it is 1, then you are likely dealing with a skeletal dysplasia. Now, the femur length head circumference ratio is another important parameter when you are trying to differentiate whether the abnormalities you are noting are due to skeletal dysplasias or a normal situation. Another one is abdominal circumference, thoracic circumference ratios. These are also reliable for the detection of severe skeletal dysplasias. Then we also need to look at degree of skeletal ossification. This should be assessed routinely, although it is usually evaluated by subjective impression. Examination of the acoustic shadow and the echogenicity of the bone itself are often helpful. However, the degree of skeletal ossification cannot be well judged. Only the most extremely osteopenic bone can one appreciate diminished ossification on the sonogram, and more so when you are looking at the fetus and examining it in early trimesters of pregnancy, when the bones are less echogenic because they are not well ossified or mineralized. Now, most anomalies of the extremities are isolated. However, some are presentations of some syndromes. Now, let's look at this neonate delivered, and it is a classical case of thanatophoric skeletal dysplasia. All the features are here. Global shortening and bowing of long bones, narrow chest, pulmonary hypoplasia, and clover leaf skull. These are classical features of thanatophoric dysplasia. And this is a lethal skeletal dysplasia. So when you see these features, which can be seen on ultrasound, then you can safely make a diagnosis of a thanatophoric dysplasia. Now, as a rule of thumb, when one anomaly is identified, one has to systematically look for other anomalies. Now let's look at this image. This is an image depicting the upper and the lower limb, but we are particularly concerned about the upper limb, and you can see the humerus. In this particular ultrasound image, the humerus is bowed. So when you see bowing of a bone, especially long bones, then you begin to think about other abnormalities, and you have to look closely for them. Perhaps they may be there. Now, what about this image? In this image, you can see that it is an image depicting the lower limb, and you can see the tibia and the fibula. They are all bowed. And when you look closely at the foot, you can see that it is clubbed. The toes are normal because there are 5 toes, and the bones of the toes are well mineralized, as well as the bones of the tibia and the femur. But the abnormality here is clear, and this is a classical case of a camptomelic dysplasia. And in this particular case, as I said, we are looking at longitudinal scan of the tibia, anterior bowing of well-ossified tibia and fibula. Now let's look at another abnormality. You can see in this case 2 bones, well-ossified bones, but this particular bone is interrupted, and it is due to fracture. There is a fracture in that particular bone. Now, this, if you note a fracture, it is not a normal thing, and it can occur even in fetal life. And sometimes when you note a fracture, you will have seen that there is also callus formation, which is not the case in this particular image, but you can see also evidence of callus formation when the bones have started healing. So presence of fracture is not normal in a fetal long bone. When you see it, it means there is a problem. And in this particular case, is a longitudinal scan of the upper extremity, the bones poorly ossified and fracture in osteogenesis imperfecta type 2A. This is what happens in this case. And the bones that is fractures, that is depicted as being fractured, is a case of osteogenesis imperfecta type 2. Now this image, if you look closely, this particular image is an image of the tibia, but what is clear is that it is poorly echogenic, hypoechogenic, meaning that the bone is not well mineralized. And again, this is humerus, and you can see that even in this case, the bones are not well mineralized. So hypoechogenic bone, due to poor bone mineralization, is also an indication that there is a pathology, there is a problem. So you have to look closely at that particular fetus. Now, limb anomalies can be part of clinical syndromes. One particular syndrome is the so-called amniotic band syndrome, ABS, or amniotic band disruption complex. Is the names, the 2 names are just talking about the same thing. It is a classical example of disruption as it is non-embryonic. So what do I mean by this? It is non-embryonic because the process does not arise in the embryonic fetal life. It is something that came up later in life due to band formation in the amniotic sac. And there are 2 theories to explain it. One is the Steyer-Montgomery theory, enunciated in 1930, and the second is the Thorpin or extrinsic theory of 1965. We are not here to talk about these theories. I've just mentioned them for us to have an idea about the explanation as to etiologenesis of amniotic bands. Now, bands may involve different parts of the body. It usually leads to constriction, and in severe cases, amputations. The constriction is what will occlude the blood vessels. And if that particular place is severely constricted, the blood vessels will be obliterated, and then that particular part, in extreme cases, may be amputated. Also, there are external clinical manifestations in the limb, and we have three things or a triad to explain them. One is the constriction rings, second is acrosyndactyly, and the third of the triads is limb reduction defects. So these are classically what we see in amniotic band syndrome. Now, when you look at this image, we have a constricted area. It is a limb, okay? You can see evidence of constriction. In this particular case, there is still continuity of the bone. However, the constriction is very clear and is due to amniotic band syndrome. Now, let's look at this other image. In this case, there are other things that we have to note. Number one is the constriction in the soft tissue. But when you look at the bone below, you can see that it is not continuous. Okay? So the sonogram here shows constriction deformity depicted by the arrowhead of the lower extremity caused by an amniotic band, resulting in amputation of the fibula, that is this bone is being amputated because the other part is not evident here. And distal soft tissue swelling, you can see that distally the soft tissue is swollen, and these are features virtually diagnostic of amniotic band syndrome. And if you look at these pictures, you can see the range of damage. In this one, there are bilateral constriction toward the feet, but it is still intact. But in this one, there is severe constriction here, and you can see distal swelling of the foot. But in this one, you can see that the limb shown here by the arrow has been amputated, and this has occurred in utero. Now let's talk a little more on skeletal dysplasia. Limb anomalies form part of the features of skeletal dysplasia. Some dysplasia present with irregular growth of fetal arms and legs. And depending on the type, also depending on the lethality, other features may be present. Thanatophoric dysplasia, where you have short bowed limbs, short narrow chest, and clover leaf, is a classical example of a severe or an extreme case of skeletal dysplasia. And like I said earlier, thanatophoric dysplasia is lethal. In the case of camptomelic dysplasia, you have mild limb shortening, bowing of the femur and tibia. And in osteogenesis imperfecta, you have long bones with fractures. We have seen a case much earlier in the presentation. And in achondrogenesis, you have short limbs, short thorax, and large head. So these are the basic or main dysplasias that we see in clinical practice, in ultrasound examination of fetuses. Now let's look at this also image, which is an image I have shown earlier of a case of thanatophoric dysplasia, but I've taken an image of the humerus of this fetus, and you can see it's very short. And this is also shown in the live picture of the fetus after delivery. So it's a case of thanatophoric dysplasia. And you can also note the constricted chest. And the constricted chest is a harbinger, telling you that you have to look at the lungs. because the condition is associated with pulmonary hypoplasia. Now let's look also at the hand and foot anomalies. Sonographic examination of the hand and feet are important adjuncts in the diagnosis of genetic defects. For example, fetuses with trisomy 13 have post-axial polydactyly of the hand and the feet, which can be seen as early as 14 weeks of gestation. Soft tissues may not be shown on the sonogram. So when the toes and the fingers are fused, it is only the bones that will be shown to be fused. The fusion will only be demonstrable in the bones. Now let's look closely at this ultrasound image. It shows post-axial polydactyly. You can see an excess digit. There are 5 digits, but on the lateral side there is an extra digit, which is depicting polydactyly. So you can make diagnosis of polydactyly. And like I said, polydactyly can be an isolated pathology. However, it may also be associated as part of a syndrome. Now, I mentioned fusion as in syndactyly. If you look at this picture, you can see that the 2 middle fingers are fused. And we can appreciate the fusion because the bones of the 2 middle fingers are actually fused. You cannot differentiate them. The soft tissue fusion you cannot actually appreciate very much with the ultrasound. Now, distinguished ladies and gentlemen, let me conclude this presentation by saying that sonographic imaging of the fetal extremities is critical in diagnosis of fetal anomalies. It helps in preparing the mind of the parents, counseling them on management, both prenatally and postnatally, and counseling them on the prognosis of the particular condition that is identified in their babies. And making accurate diagnosis is the basis of management, and such may not be possible without adopting a systematic approach, as we have discussed in this particular presentation. And comprehensive knowledge of fetal anatomy and experience in fetal imaging is key to this examination of fetal extremities. Distinguished ladies and gentlemen, thank you for listening.